Hello everyone, welcome back to the channel MedPharmaco Essentials. Today this video is all about antimicrobial stewardship. So let's start with the introduction. In the pre-antibiotic era, where the virulent organism would spread infection from one patient to the another very rapidly, will lead to pandemic, epidemic and outbreak conditions. Then, discovery of the first antibiotic penicillin in 1943 was nothing but the magic bullet that effectively cured life-threatening infections. Next 3 decades saw a huge discovery of various antimicrobial reagents. Discovery of new molecules decreased from 1970 to 1987, and the phase was also called as discovery void. Frequent and inappropriate use of newly discovered antibiotics have led to antimicrobial resistance. Antimicrobial resistance has emerged as a major public health problem all over the world. Infection caused by resistant microbes fail to respond to the treatment because of limited treatment option that results in prolonged illness and greatest risk of death. If treatment fails, the patient will have longer period of infectivity that may lead to increased number of infected patients in the community. Once organisms become resistant to one of the first line antimicrobials, as a second line antimicrobials may be very costlier for them to afford, and thus patients sometimes may also lead to treatment failure. It is estimated that 50% or more of hospital antimicrobial use is considered to be inappropriate. Implementation of antimicrobial stewardship program will improve the quality of patient care, patient safety, reduce treatment failures, increasing frequency of prescribing appropriate therapy and prophylaxis. It will also reduce the Clostridium difficile infection rates, and it will reduce the antimicrobial resistance. Inappropriate use of antimicrobials leads to the following: casual association between antimicrobial use and emergence of antimicrobial resistance. Antimicrobial resistance is more prevalent in hospital-acquired infection than in community-acquired infection. Healthcare-associated infections are more likely to be caused by resistant strains, especially in those who have received prior antimicrobials. Hospitals that have the highest rate of antimicrobial resistance also have the highest rate of antimicrobial use. Patients exposed to long duration of antimicrobials have an increased risk of colonization with resistant organism. Second is mortality rate correlates with the presence of multi-drug resistant organism. Association between development of antimicrobial resistant in Staphylococcus aureus, Enterococci, gram-negative bacillus, and mortality. Enterococcal infection have been associated with mortality rates exceeding 30%. A meta-analysis of published studies have found that patients with methicillin-resistant Staphylococcus aureus bacteria have an increased risk of mortality compared with methicillin-susceptible Staphylococcus aureus. Killing the beneficial bacteria. Consensus about antibiotics focus on bacterial resistant but permanent changes to our protective flora have more serious consequences. Collateral damage. Child averagely receives around 10 to 20 courses of antibiotics before 18 years of age. Antibiotics affect our resident microbacter and may not fully recover after the course of antibiotics. Overuse of antibiotics may be contributing to obesity, diabetes mellitus, inflammatory bowel disease, allergies. Why we need to improve antibiotic use? Antibiotics are the only drugs where use in one patient can impact the effectiveness in another. Improving antibiotic use improves patient outcome and saves money. Antibiotic misuse adversely impacts patient and society. Antibiotics are misused across the healthcare and thus emergence of antimicrobial resistance is affecting the global health. What can an individual physician do? Obtain appropriate culture before starting antibiotic. Review antibiotic use after 48 to 72 hours and check to continue antibiotic or switch or stop. Stop antibiotic in patient with alternative non-infectious diagnosis. Optimize dosing and duration of antibiotic therapy. Avoid unnecessary use, especially in viral upper respiratory tract infections. Antimicrobial stewardship must include the evidence based education of physician and about appropriate drug dosing interval and duration. De-escalation and optimization campaign should also be undertaken to educate and inform the public about specific indication for antibiotic use, origin and spread of antimicrobial resistance and what needs to be done to control it. Development of newer antimicrobial agent is not that simple. So, the current approaches to antimicrobial resistant is to preserve the effectiveness of the drugs which are presently available by antibiotic stewardship and maximize hospital infection control practice to limit the spread of resistance.